Good morning, everybody. We expect to get started in about 5 minutes. I would like to take this time, and we have a new distance learning coordinator. Her name is Corinne Hill.
Hi, hello.
Looks like we're all good to go. All systems are going, and we'll get started at 10 o'clock sharp. Thank you so much for joining us.
Thank you.
Good morning, everyone. I'm Mark Weeks, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Discharge Planning, Aftercare, and Recovery Supports. This webinar is being made available through a collaboration of the Florida Department of Children and Families Offices of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the Q&A panel. The button to open the panel is usually located in the upper right side of your monitor. Please note the Q&A panel, or please use the Q&A panel to send any questions you have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor audio, there are a few options to try on screen right now, and these options are posted in the in-chat panel as well. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and material used in today's presentation will be made available on the FADA website within 30 business days. A helpful hint, the archive video displays what looks to be an error message but is only a delay buffer. Ignore it, hit play, and enjoy. To access the recording and PowerPoint, go to www.fada.org, Resource Center, Training Library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families to help participants track credits earned through attendance. We host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to the evaluation form on the FADA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADA as a part of the registration remains confidential. Statements of credit will be posted within 30 days after the evaluation closes in the individual personal development journal for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note the evaluation will close at midnight on Saturday, January 18th. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your certification number when you register with our site. Note, please, that WebEx monitors arrivals and departures of attendees, provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance. If you do not attend the webinar and the entire webinar, we are not permitted to provide partial credit. And now, our presenter today, Gabriela Zapata-Alma, is the Director of Policy and Practice of Domestic Violence and Substance Use at the National Center of Domestic Violence, Trauma and Mental Health Care, as well as faculty at the University of Chicago, where they coordinate the Advanced Alcohol and Other Drug Council certification programs. Gabriela brings over 15 years of experience supporting people impacted by substance use disorders, trauma, housing instability, HIV and AIDS, and mental health conditions, providing direct services, training, advocacy, and consulting, and leading programs using trauma-informed approaches, motivational interviewing, harm reduction, gender response care, housing first, and third-wave behavioral intervention. Gabriela has been recognized with numerous awards, including the Health and Medicine Policy Research Group's 2018 Health Award and the 2017 Rising Star Award from the Illinois chapter of National Association for Addiction Professionals. Gabriela provides training and technical assistance related to serving marginalized communities impacted by trauma and other social determinants of health, nationality, and internationality. And now I would like to welcome our presenter, Gabriela. I will turn this presentation over to you.
Thank you. Thank you so much for that introduction and for the warm welcome. And thank you so much to the Florida Department of Children and Families and the Florida Department of Association of Behavioral Health for having me. I always love working with all of you, and just always come away so impressed with the breadth of knowledge and services and skills in Florida. And in February, I'll actually be there in person giving some in-person workshops on administrative discharge and how to avoid and decrease administrative discharge. So I look forward to hopefully meeting many of you in person. So today we'll be talking about discharge planning, aftercare, and recovery support. And here you have my email. Always feel free to reach out to me. And then a little bit about our center, the National Center on Domestic Violence, Trauma, and Mental Health. Our center is funded through the Department of Health and Human Services, through the Administration for Children and Families and the Family Violence Prevention Services Act. And we are a special issue resource center dedicated to addressing the intersection of domestic violence, trauma, substance use, and mental health. So our learning objectives for today, we're going to describe the key elements of continuing recovery planning. We're going to talk about and identify some trauma-informed discharge practices and aftercare services for individuals with substance use disorders and people who have experienced domestic violence and trauma. We know that there is a high correlation between people who experience substance use and substance use concerns and being targeted for intimate partner violence and other forms of victimization and trauma. And then we're also going to become familiar with recovery management checkups as an evidence-based and core component of aftercare services. But first off, when do we even begin the process of discharge planning? And I invite everyone to write into the chat box, when do you start talking about discharge planning within the services that you provide? And I'll give everyone a moment to find the chat box and start typing in your responses. At admission, at outreach, upon admission, at intake assessment or orientation. That is exactly right. So discharge is something that we start talking about from the very beginning, understanding that treatment has a beginning, middle, and end, and that we start planning for when, how we might know that treatment is effective, that people are making progress towards their goals, and what are some things that need to be in place for people as they move forward and complete their treatment and then after treatment. Thanks, everyone. So why are discharge planning and aftercare important? Well, something that we've known just anecdotally for many years in our practice evidence and our practice experiences is that recovery is not a straight line. That it's not just you go to treatment and, snap of the fingers, like, okay, all done now, all better now, right? That for most people, recovery is cyclical, that it's a many kind of winding path. Now we have research that shows us this as well. So this research here that's quoted followed 448 people over 2 years, and the results found that about a third of participants transitioned from one point to another each quarter, so every 3 months. About a third of that 448 people moved from being out of treatment to in recovery to in treatment to out of treatment and using substances again, so that these kind of three different stages people are moving in and out of, and that 82% of that 448 people transitioned at least once, so moved from kind of one of these stages to another stage at least once, and that 2/3 actually moved many times. And so in this way, in our practice, sometimes we talk about this as feeling like there's a revolving door, and many times for us, it can feel like we wonder, are we making a difference? Is what we're doing working. And for some of us, that may even kind of lead to some feelings of burnout. And so something that this research helps us to understand is that discharge planning and aftercare are exceptionally important, and that when people are returning, that's actually a success. That's not a failure. That doesn't mean that it didn't work. It means that these concerns come in waves, they're cyclical, and the very fact that someone feels safe enough and welcome enough and that our services were helpful enough for them to come back means that we did something that was successful, that we have built an environment where people are still hopeful about their recovery and feel that we can help in their recovery. So the importance of discharge planning. So here, the connection with ongoing community-based recovery support has been found to be associated with better recovery outcomes. That, recovery isn't just something that we can check off a list and say, okay, done, all better now. That it's really, recovery takes, from some people, even a lifelong approach to reintegrating within community support, safe community support, supportive community support. And then aftercare services have been found to support recovery maintenance, so maintaining those recovery goals. And this can be something as simple as phone-based check-ins. So a lot of times when we think about aftercare services, we think it has to be like a huge department, or there has to be a team wholly dedicated to this, when actually it's been found that recovery checkups and active linkage to recovery supports following treatment can be low cost and can be as simple as telephone-based support and still have a positive impact on supporting the maintenance of recovery goals. And then research has also found that by combining both treatment and recovery support groups, so combining discharge planning and those aftercare services had much better outcomes than somebody who just had the ability to access one or the other. So that there's actually a statistically significant effect of combining the two. So what's our role in all of this? So we play a key role in that we are in a position to really individualize someone's discharge planning. We can help connect people with community resources. We can support those transitions, knowing that transitions are times that are difficult for all of us, but especially when we're newly, just newly have taken some action and had some early success in our recovery goals. And we can actively support that early engagement in community-based recovery support. So really acting as that bridge. And so a lot of the considerations and different strategies that I'm going to talk about, there are the same across different levels of care. But there are also some things to consider in specific levels of care, like if we're in residential services versus outpatient services. And I'll also highlight some of those key pieces. So best practices in discharge planning. We want to start early. It's also ongoing, so it's not just that we make a discharge plan and write it on a piece of paper and it goes and lives in a file that no one ever looks at again. So it's ongoing planning, it's dynamic planning, and that included in that is continuing recovery planning, and I'll unpack what the different pieces of that is. And then supporting the continuity of care, and we'll talk more about that as well. So, as many people mentioned in the chat box, thank you so much for participating. We begin discharge planning at really the first contact, the orientation, and at the latest during intake. Otherwise, what can happen is that when people start to have some relief from their symptoms, when people start to have some gains in their recovery goals, and then we bring up discharge planning for the first time, sometimes people can feel really nervous and feel like I'm finally making some progress here, and now it's the thing that's helping me is going to end. It's going to go away. And what we can see is very commonly a resurgence of the kind of original problem or those original symptoms. And part of that is really natural response to the fear of something we have found to be supportive and helpful. Now we're talking about that ending, right? Or people can feel really caught by surprise and put off the conversation. Like, I'm not ready to talk about that. I still have, a couple more weeks. I'm not ready to talk about that. And then time can move really quickly, and then we're at the point of discharge, and we haven't had the opportunity to make a really robust discharge plan. And so these are a couple of the reasons why we want to start that early in the process, as well as just being able to talk about how will we know it's working? How will we know that this is meeting your needs and supporting you and meeting your goals, and that all of that feeds into the discharge planning conversation? So I got ahead of myself. Here we are. How will we know when treatment, or at least that level of care, is complete? So what are the indicators that we'll look for? And we want to define those collaboratively, so really starting with what the person means as would be signs that they would notice about themselves that they were making some forward movement towards their goals, and that those indicators can be understood, mutually understood, both by the person themselves as well as the treatment team. And then from there, what will be the data source? So it's not enough to say, well, I know because I'll feel better, right? So that's important, and that's a starting place, and let's go deeper from there. What does that look like? What does it look like to feel better? Does it mean that I'll be experiencing less intense cravings? Will it mean that I will have learned some different coping skills, some positive coping skills? And this is where we can help to really operationalize those signs that treatment is working. And that's not only important for discharge planning, that's also important for motivation and treatment. Because a lot of times we tend to measure our own success, and I mean like personally in our lives, by the end goal. And we miss all of those mile markers along the way that tell us that what we're doing is headed in the right direction, what we're doing is working. And when we're missing those, it's easy to feel hopeless. And we know that treatment is hard work for people. Recovery is hard work for people. And so we need all of those, recognition and awareness of those early successes, of those incremental wins along the way, so that we can see that what we're doing and what we're working so hard on is actually having an impact. So that really helps engage people in their treatment and build their motivation. And it also helps reduce burnout for staff, so that we don't feel like, wow, I'm working so hard, but I'm not really seeing anything coming out of this. I don't know if I'm helping, because that can also be very difficult for staff. Now, having really kind of mutually understandable and clear indicators and data sources are not only helpful for that motivation and for discharge planning, it's also helpful for just our reimbursement and documentation, understanding that the services that are provided within a treatment center are based on medical necessity. And so we need to be able to document also when is treatment no longer medically necessary, as evidenced by the reassessment of criteria as defined by the American Society of Addiction Medicine. So also having that clear for ourselves, for documentation, and for regulation and funding and insurance compensation. So all of that kind of hooks into itself. And we know that starting early also supports transparency, consistency, and predictability while supporting the self-determination and autonomy of the person in services. And these are all essential building blocks of trauma-informed approaches. That there's a clear link between my needs as a person in treatment my goals, and then the services that I'm accessing and the treatment interventions that I'm engaging in, as well as how we're measuring progress and success. And that when somebody already has experiences of trauma or experiencing the effects of trauma, that feeling kind of like, oh my gosh, now we're talking about discharge planning and it's out of the blue and I didn't see it coming. Even when people maybe have told us, hey, people tend to stay in this program from, anywhere from 2 to 4 weeks or 1 to 3 months. If we haven't been kind of planning for it all along, once we do start planning for it, that can feel like it's out of the blue and that why is this being brought up to me now? And that can feel potentially even re-traumatizing for people who have experiences of traumatic loss, of feeling like their power and control is taken away from them. And we know that in our services, there's a lot of things that can feel really foreign for our clients. I remember I once had a client say to me, coming to treatment was like having to learn a whole new language. And so there's already so much that can feel unfamiliar. And when we understand that trauma, including intimate partner violence, is characterized by experiences of having our power and control taken away from us, feeling overpowered and feeling overwhelmed, that we want to do our best as service providers to set up a situation where there's transparency and predictability so that people have the maximum amount of voice and choice in their services and that we're not kind of unconsciously or accidentally re-traumatizing people. And so that ongoing planning includes identifying needed resources and facilitating access to potential community resources and partners early in the process. So throughout care and aftercare, we want to be nurturing recovery management skills and community reintegration. And we want to continue reviewing and updating as people's needs emerge and evolve. What I see as my discharge planning needs on day 1 are not going to be the same as what I'm recognizing and identifying and what's evolving and coming up for me on day 15 or in more longer term kind of intensive outpatient or outpatient settings, a month or 2 down the road. So who's at the table? Who's involved in discharge planning? So here, the importance of using a team approach. That our overall approach is collaborative, person-centered, really basing our services on self-defined needs and supporting the individual's autonomy, their own decision-making, their own informed decision-making. And so who's involved is absolutely the person accessing services, any safe social supports that they define in their lives as being safe social supports and that they want to be involved in their discharge planning. This is especially important that the person that we talk to them kind of one-on-one around who they would want to involve in their care, because there can sometimes be people who present as a concerned social support, but may actually be somebody who is seeking to exert power and control and abuse the person in our services and maybe trying to control that person's services or our perception of that person in our care. And so it's always important to talk with people one-on-one about who's a safe social support, who they want involved in their care, and then engaging family members and other significant social supports. And then, of course, the treatment and recovery team. So here, I'm having an interdisciplinary approach that includes direct service staff, including the treatment counselor, recovery support, and peer-based support specialists. And here are the different parts of the successful discharge planning that is individualized and comprehensive, that it puts together a well-coordinated system of continuous support. So we're really seeking out where are the potential gaps in support and what do we need to do in order to really bridge those gaps. How can we extend our services and how can we engage community support and helping to kind of meet us and work with us so that we can bridge those gaps, which includes access to those community resources, community reintegration. Many people with experiences of substance use disorders have become very isolated within their communities, very isolated from safe and recovery-oriented social supports and systems. And we know that recovery from both substance use and trauma are relational. And we know that trauma, including intimate partner violence, also tend to lead to experiences that are very isolating for people. And so a big part of our discharge planning is helping to bridge that community reintegration, but always defined by the person and led by the person. So it's not us saying, hey, you better go to this thing or else your recovery is not going to work, right? That's not a person-centered approach, but that we're invitational and helping people to say, develop and become aware of what are all the different options and resources and what do they feel like they're willing to try and might be helpful for them. And that it's practical, realistic, and maximizes available community resources for their benefit and includes continuing recovery planning. So we want to think about discharge planning as the culmination of ongoing assessment and planning, and that a cookie-cutter approach is not going to work here. So we have to actively engage the person in defining their own needs and from their perspective, what would be helpful, and then providing information on available resources. And within that individualized approach, developing our responsiveness to the person's experiences, their culture, their personal values, and what are their needs, particularly around any co-occurring concerns, including, family needs, housing instability, any chronic health conditions, mental health concerns, trauma recovery needs, potentially eating disorders, which we do know that there is a high co-occurrence of eating disorders, and this is an area that there's not really enough research and enough interventions around. And then safety needs, including safety planning and connection to domestic violence services for those experiencing intimate partner violence. We know that a large number of people who have diagnosable substance use disorders also have lifetime experiences of intimate partner violence and may experience ongoing stalking and victimization and targeting from an ex-partner, and that also a large percentage of people have current, active, ongoing targeting and abuse by the intimate partner. For women, rates as high as 90% have been found in substance use treatment programs for a lifetime experience of intimate partner violence, and then active, ongoing, anywhere from 30 to 60% of women in substance use treatment. So, and the resources are central to discharge planning. And maybe this goes without saying, the discharge plan needs to be written down. It all needs to be written down in ways that are mutually understandable. So not just written down in ways that the counselor understands, but that the person can understand and is relevant for them as well, with copies provided for the individual as well as kept by staff. So considerations by level of care in discharge planning. So many of the discharge planning goals, really most of the discharge planning goals and needs overlap and are continuous across the levels of care. But we'll talk about two particularly vulnerable transition parts, and those are from withdrawal management to active treatment, as well as from inpatient treatment, so inpatient or residential treatment to outpatient-based treatment. Those are 2 points where people are at kind of highest risk for slipping between the gaps in our systems of care, and then, potentially returning to a lot of the problems that they were seeking help with. So thinking about withdrawal management. So withdrawal management is available at every level of care. And withdrawal management alone is not considered treatment. So ongoing recovery support is critical for those completing withdrawal management services. Research has found that detox only, so withdrawal management only in the case of opioids, without stabilization and linkage to ongoing medication-assisted treatment, has actually been found to increase the risk of fatal overdose. So that accessing detox-only services for opioids actually resulted in a higher risk for fatal overdose than when compared to people who didn't access any detox service. So here, the overdose prevention education and access to naloxone and naloxone training, the overdose antidote for opioids, becomes crucial, becomes so important. And there's a lot of new evidence coming out around promising practices. So some of those promising practices include bridge MAT clinics. A bridge clinic is really low barrier medication-assisted treatment clinic where people can come in and get access to FDA-approved medications for opioid use disorder, including Suboxone or buprenorphine plus naloxone, and potentially methadone and potentially naltrexone. And it's low barrier, and so they can keep coming to this bridge clinic until they're able to get into a more formalized treatment. Because we know that treatment on demand, meaning easy access into services as soon as we need them, is really what's needed to combat this epidemic. But we know that many of our communities, I'll say most of our communities, don't have the ability to connect people to treatment kind of same day. And so in many of our treatment programs suffer from long wait lists. And so these bridge clinics can be ways where people who need access but don't have that access yet can access some of these life-saving medications while they're also engaged in services to help engage them into more formal treatment and holistic treatment. We also know that recovery coaching and peer-based support can be essential to this really vulnerable point between withdrawal management only services and moving into treatment. And we've seen how that can include warm handoffs and seamless care coordination across settings. One really great example is the kind of emergency department recovery coach and peer-based support program, where somebody is taken to an emergency department because of an overdose, and they receive that emergency medical attention, and while they're there, they're also met by and engaged by somebody who is a recovery coach and who is many times someone who is in long-term recovery and has their own lived experience. So really the importance of that peer-based support, and that person is trying to build that relationship that is really person-centered and about whatever that person who's in the emergency department feels that they need that can help them in that moment. So that might be connection to recovery resources and treatment resources. It might also just mean just ongoing support in connection to housing and other things that the person may need. And so it's a really flexible intervention that meets the person where they are. And we've seen really good research outcomes with that. And then that seamless care coordination across settings. So that care coordination that follows the person rather than to really bridge those gaps between care systems. And now I want to share a story of the unfortunate reality of when there's detox and discharge without that kind of seamless care coordination and services following the person and that active discharge planning and aftercare. So one of my participants that I worked with many, many years ago, over a decade ago, he accessed detox-only services, and he had no discharge planning or aftercare. And at this point in my career, I was really pretty fresh in the field. So actually, it was more like 13, 14 years ago. I was really fresh in the field. I was a housing case manager, and I had not yet gotten much training in substance use or substance use treatment at that point in my career. So he accessed detox-only services and was handed a list of methadone providers upon discharge, but there was no other discharge planning. There was no warm handoff. There was no linkage or care coordination. He went to detox-only services at a local hospital because a local treatment provider in our area didn't accept his insurance and didn't have an intake appointment available for over 30 days. So he was in detox for 3 days and then given a list of methadone providers upon discharge with no other planning or aftercare. And none of the methadone providers on the list were accepting new patients, and none accepted his insurance. He's somebody who was accessing Medicaid, and at that point in my state, Illinois, methadone was not reimbursable by Medicaid at that point. It now is, but at that point it wasn't. And so, he began using heroin again the next day after feeling really hopeless in his search to find ongoing treatment and care. And then after that happened, he was arrested attempting to purchase drugs. And because he was on parole, it was a parole violation, and he went to prison. And so discharge planning and aftercare support are not only critical for supporting long-term recovery outcomes, but they also help prevent even worse outcomes like incarceration or death. Now, another critical kind of vulnerable point in discharge planning is the transition from inpatient and residential services to an outpatient level of care. And so here, we need to really think about safety needs. Safety first. We should always be thinking about safety needs, but especially when someone is moving from that kind of controlled environment into kind of a natural environment, it becomes even more important to address some of those safety needs. And in addressing safety needs and planning for safety needs, we look at risks, both risks to their recovery gains as well as personal safety, including overdose education, domestic violence safety planning, and other safety concerns. Now, there are a lot of different kinds of services and needs that domestic violence advocates are really the experts in providing. And so while it's important for us as substance use treatment providers to understand some of the basics around domestic violence and understand some of the basics around the services that are offered and safety planning, it's also really important for us to connect with those community-based resources so that people can get some of the best services possible around their safety needs. In outpatient care, so here, engaging in that step-down outpatient care, this is most often going to be focused on substance use, but may also need to include outpatient services around mental health and or trauma care. And so being aware of what are some of those intersecting and co-occurring needs that people have, and then working to connect them with a program, hopefully one integrated program that can help address the potentially co-occurring conditions that they may experience, but if not an integrated, at least a collaborative kind of approach. But we do know that integrated approaches do have much better evidence whenever they're available. Of course, housing and vocational support, and how safe is their housing environment, connecting people with that recovery support network, and then recovery support for the family. What are the family needs, and how have we helped to prepare and support the family for ongoing recovery? are there unhealthy behavioral or communication patterns within the family that have contributed to the substance use disorder? Has the family received support to address any of the impacts of the substance use disorder on the family? We don't want to send, people back into situations where there are potentially some unhealthy dynamics and the family has been very hurt by the substance use disorder, because all of that is really setting people up for a relapse. And so what resources or recovery support services are needed and desired to support the family? And then, of course, community reintegration. So now I want to share a time about when that supportive discharge planning went right. I want to tell you about a success story for a participant who was able to access supportive discharge planning as part of her inpatient treatment and the difference it made. So this is now when I was in formal treatment as a formal treatment provider. So Marcy called us when she was about halfway through her residential treatment and shared that she would be finishing her residential treatment in about 2 weeks and wanted to know how to get started in our intensive outpatient program as soon as she discharged from residential treatment. We also talked with her about some of her other needs, and she let us know that she'd need housing when she finished residential treatment, but that she was working on that with her inpatient treatment team. We coordinated getting the appropriate releases of information so that we could coordinate with her and her inpatient treatment provider so that we were able to do her intake immediately upon her discharge from inpatient. And, of course, with written informed consent, we were able to share clinical records to facilitate really a seamless transition. And so she was able to move into a recovery home and attend our IOP with no gaps in care, including no gaps in her medication-assisted treatment. With us, she accessed substance use care, including MAT, mental health care, including psychotropics, trauma care, and a women's group. We were also able to help her access permanent supportive housing, which she qualified for because she was living with a disabling condition. In about 12 weeks, she was ready to step down from intensive outpatient to outpatient, and then she was in our outpatient for an additional 6 months. During that time, she decided she wanted to become a substance use counselor, and she started taking classes to earn her certification in counseling around alcohol and other drugs. So when she completed her outpatient, by the time she completed, she had a strong recovery support network, had a strong recovery-oriented relationships with family, was pursuing her education, had stable and secure housing, and was able to access ongoing medication-assisted treatment through her primary care provider, which was something that we were able to connect her with through active discharge planning. She engaged in 6 months of aftercare services upon completing outpatient, and she was active in our alumni community. When we checked in with her 12 months after completing treatment, she was maintaining her recovery goals and continuing to pursue her certification and her education. So continuing recovery planning. This flows from dynamic treatment planning. So it just how in treatment planning we're reassessing what needs have been addressed so far in treatment. What are needs that continue to be present, and how do our services need to potentially evolve in order to better meet those needs? And what new needs are emerging or evolving that we need to take into account within that treatment plan? So just how treatment planning is an ongoing, living, breathing clinical process, continuing recovery planning just flows directly from that dynamic treatment planning. And the goals are maintaining those treatment gains, supporting greater life goals, really supporting that recovery capital, both the internal and external resources that help along the path of recovery, as well as focusing on some aftercare planning. And so here we can think about, what are some of the core values that are really important for the person? What matters most to them, and how can we build on that? What are some of their quality of life goals, and how can we help them plan around that? How can we help them identify what some of those different, actually, let me go to the next slide. Here we go. So identifying what are some of those situations that present a high risk to the person's recovery gains. And then a lot of times we talk about this as identifying cues to use or identifying kind of relapse triggers. For many people, we can think about, that negative internal state, such as anger, betrayal, loneliness, that a lot of those can be cues for relapse or for kind of returning to use. And then most importantly, identifying what are some of those high-risk situations, and then what can we do about it? What are some things that we've learned in treatment that worked for us in treatment, and that we think would be realistic and working for us in continuing our recovery? So how to avoid or prevent the situation, how to escape from the situation, how to cope with the situation, and then how to engage recovery support within that situation. So we can't always avoid it, we can't always prevent it, we can't always escape the situation, and sometimes our coping might work a little bit, or we might have a hard time using some of those skills in the moment. So then how can we reach out to our recovery support system in that moment? And that this is a really individualized coping toolbox that looks at what are the craving experiences like for us and our cues to use, and how do we cope with that, as well as what is our recovery setback response plan. So if and when we do experience a momentary setback in our recovery goals, how can we notice that? And what can we do about it? Kind of like an emergency preparedness plan. So the plan to support maintaining treatment gains beyond the completion of treatment builds upon the many past counseling sessions, as building those coping skills and planning for potentially risky situations is something that happens throughout treatment. So this plan then extends the conversation to help the person make a plan for applying what they've been learning and doing in treatment to their experience after treatment. And here, also thinking about safety needs. Are there additional or changing safety needs that come with treatment completion? How does the person's environment support or threaten their recovery? Is there someone in the person's natural environment who's likely to pressure or even coerce the person into using substances? Is domestic violence safety planning needed? And can we offer that through cross-trained staff or collaboration with DV resources? We also, in anticipating situations and making that recovery setback response plan, this will be very familiar if you're already using cognitive behavioral therapy. So a lot of the same skills that we use in CBT. And so Kim will talk a little bit more about what that recovery setback response plan can look like. So here is a sample that is taken from the National Institute on the Alcoholism, and I'm blanking on what the other A's stand for, but NIA. And this comes from their CBT manualized CBT, which is a great resource. And so if I encounter a high-risk situation, it's kind of a plan for what someone can do if they encounter a situation that is risky to their recovery goals and maintaining the recovery goals. And of course, this is just an example and something that we could certainly build off of, but that we would want to really individualize for the person. And then a sample from that same resource of a recovery setback response plan. And here, our goal is to really help people prevent a momentary setback from becoming kind of a full return to a substance use disorder, or kind of a full return to the depth or the severity of the substance use concerns that they first came to treatment with. And so that's part of the goal of that recovery setback response plan. So really just step by step, because when we're in that crisis, it can be hard to know what to do, and we can feel a sense of just overwhelming shame and self-blame. And so this is a really important resource for people to be able to know, like, hey, not all is lost, and here's a way to get back on track. So getting rid of the substances, getting away from the place that I used. And then there's kind of this self-affirmation and self-soothing piece that people can read out loud, calling a recovery support for help, and then reaching out to a counselor, a recovery coach, a sponsor, someone who can help and provide support, so that we can, talk through what were some of the cues, what were some of the, pieces of that high-risk situation, and how did I react to them, and how can I update my continuing recovery plan so I'm going to set myself up for success, that I'm more able to cope with a similar situation in the future. And always remembering that this is just a temporary detour on the road of recovery. This is not fate. This is not, we really want to work against that sense of hopelessness. And knowing that recovery, that hope is a really primary ingredient in recovery. And then looking at greater life goals and needs. So what's most important for the individual? What are the greater life goals? And this is really important because recovery is hard, folks. And a lot of times what helps people to continue to maintain and move forward in their recovery is being able to connect with that kind of deepest sense of their core self, of what's most important to me. And then that really helps, as we dig deep, that really helps to be able to kind of continue and persist in what is, the hard work of recovery. So when I would be doing an intake with someone, a substance use intake, and I'd ask them, what brings them in, what's their goal in seeking services, the most common response I would get would be, well, I'm here to quit drugs, right? Like, you're a drug use counselor, I'm here to quit drugs. And my response was always, okay, tell me what quitting drugs would help you do in your life. Because the point of quitting drugs is not quitting drugs. If we could manage our lives, if we could have, all those life goals and the things that matter to us, if we could, maintain jobs and live independently and have positive family relationships and feel good about ourselves and, feel healthy, not feel sick and tired, right? Like, if we could have everything that was important to us and still use drugs, then a lot of us would never go to drug treatment, right? And so what is it about changing the relationship with drugs that will allow you to do with your life, to do in your life? What's the greater life goal? And so when people can be really connected and have that greater life goal and those core values connected to their recovery, that's when we start seeing that recovery is not as brittle, that it's something that can be much more long-standing and enduring through all of the twists and turns of that recovery path and all the, frankly, hard work of recovery. And then planning for what are the remaining needs, how can we plan for those, and then if applicable, what specific actions are needed in order to satisfy any court or legal mandates. Sometimes people come to us because they're mandated through, some kind of legal system or child welfare potentially, and they may have finished the treatment portion of their mandate, but then there may be other things that they need to satisfy still. And so in their continuing recovery plan and in their discharge plan, we want to support them by having all of that as spelled out as possible so that they have kind of one place where that's really clear for them. And we know that, at least I'll speak from my own experience, a lot of times those legal mandates can feel really confusing. Even as myself, the licensed professional in the room who, is been navigating different systems, including legal systems, for a very long time. Even for myself, a lot of times those legal mandates can feel confusing. And so a way that we can really help is by advocating with some of those legal systems and being able to really get on paper what are some of the requirements, what are the remaining requirements, and then making sure that that's written in a way that is understandable for all the different parties involved. And then thinking about recovery capital, that in continuing recovery planning and discharge planning, we really want to be shoring up that recovery capital through community-based support resources, recovery-oriented social support, and also through helping the person to identify their core values and how that fits in with the experience of recovery and their recovery goals. And so just as a refresher, in case people are unfamiliar or haven't, thought about recovery capital in a little while, here is the concept of recovery capital. There are four main buckets: the human domain, the social domain, the community domain, and the physical domain. And then something that we can do is really think about how our services target each of these domains and help people connect with internal and external resources in each of these domains throughout our services. And then in aftercare planning, how can we support the person's continuing recovery and pursuit of their life goals, and what aftercare services are even available to them within our treatment setting? Ultimately, what can we offer, and what's the plan for follow-up and aftercare? And we'll talk a little more about this during our discussion of aftercare services as part of the continuity of care, as well as recovery management checkups. But here, really offering a buffet of options around aftercare services, and then helping to engage that person in planning which of those services they feel like would be helpful and how they would like to engage. So some of the challenges in discharge planning. There can be increased anxiety about the end of treatment. This is really natural. I remember facilitating an IOP group, and one of the participants just kind of saying out loud, I can't imagine this ending. I can't imagine not coming here and being able to get the support from everyone here. And he was talking largely about the other participants in the group, because at that point the group had really strong cohesion and were really helping one another. And that's a really common experience. It's a really natural experience. And if we aren't attending to it, then it's really natural for people to start kind of pulling away, even unconsciously, from their treatment game. Some other barriers are difficulty anticipating post-treatment needs. People having a sense of, overwhelm, and that they're just trying to keep their head above water, and they can't even start to imagine what they might need once treatment is over. And here we can take a little more of an active role and develop that buffet of options and really talk about what some people have found helpful, and just talk about what might they be willing to try. And let's try out some of those things while they're still in treatment with us, right? Would they be willing to try meeting with a recovery coach? Would they be willing to try a community support group? Would they be willing to try a family support group? What are some things that feel like they might be helpful, and can we just kind of dip the toe in, and that can help clarify what might be helpful and what they might want to continue doing. A lack of community resources. This is a very real barrier in a lot of different communities, and particularly in rural communities where the resources just aren't there. And so what can we do to really, peer-based recovery support is always important. And what can we do to help, connect with peer-based recovery support as well as really develop some resources within the community. And this might be more the role of potentially leadership within an organization, as well as what services do we need to add to our treatment program in the form of aftercare and community-based support, because those resources don't exist in our community. And then a lack of established protocols and training around discharge planning can be a very real barrier to effective discharge planning. And again, this is the place where the leaders of the organization, team leads, clinical supervisors, and program directors, clinical directors, this is a way that we can really help provide the structure and the resources and the support needed to successfully discharge plan. So, how can we support effective discharge planning? Written protocols, standardized discharge planning forms, training for all staff involved in discharge planning, so thinking about that interdisciplinary treatment and recovery team. We can review upcoming discharges and discharge plans and clinical staffing. This is something that in our just ongoing clinical supervision and clinical staffing, I always like to do is who's coming up on, being close to completing treatment and what is their discharge plan. Let's review that together. And a practice that I really like because it enhances both motivation and client engagement as well as trauma-informed care is inviting clients to attend their own clinical staffing. So we can talk openly around what's working for them in treatment, what do they see as their remaining needs, and how can we best plan to do the best that we can do in supporting them. Cultivating those community resources, the routine review of clinical records to provide coaching and feedback for staff. And this can really involve like a quality assurance person as well as clinical supervisors. A routine review of protocols to improve their effectiveness, and then collecting and analyzing follow-up data. And a lot of times we feel like we're just running from thing to thing and we can't possibly take the time to collect or look at data. And yet for any of us that have electronic health records, really making those electronic health records work for us. It's not just about putting data in, but it's also about how can we pull out a report that shows us what about what we're doing is actually working, and then we can have a conversation around what we can do better. And so collecting that follow-up data is useful for having real feedback on how our discharge processes are working and whether our discharge planning goals are being met. And after the break, we'll talk about some ways that we can really easily collect some data during just some routine functions of recovery checkups. So now we'll go ahead and take our 5-minute break. I have about 4 past the hour, so we'll come back at 10 past the hour.
All right, thank you, Gabriela. Yeah, 10 past the hour. That works for us.
All right, thanks everyone, and welcome back. We're going to go back to this slide for one moment and just mention that the research by this group, Barron et al., 2008, found that few programs have discharge planning processes in place, and that those that do may not be implementing their own process in a uniform or systematic manner. And so that's something to keep in mind, that even if you do have a written protocol and procedure, that doesn't necessarily mean that people have the training and the resources to be able to implement that in a kind of predictable and systematic way. Something else to keep in mind here is, what are the referral processes for your community partners, and does your discharge process align with their referral process? That's a really important piece in identifying any gaps in care and how to support continuity of care. So, continuity of care. So here we'll talk about community-based support, resource connection and gradual transitions, and aftercare services. So in community-based supports, there are different kinds of community-based supports. Here we think about mutual aid resources, such as community recovery meetings, including 12-step and smart recovery. And we can help facilitate connection to mutual aid and or recovery community organizations early on in the treatment process. We don't have to wait until kind of the end of treatment to start facilitating this connection. And a resource that can be helpful in locating your local RCOs and mutual aid resources is Faces and Voices of Recovery. They're a wonderful organization and a wonderful resource, and their website has great listings for both of these. And then also thinking about how can we support and mobilize a person's natural support system. Of course, whoever they identify as part of their safe supports and healthy supports and recovery-oriented supports, as well as people that they would want to be included in services with that we may provide. So we want to, with the person's, of course, input and informed consent, have treatment services that include any significant social supports that a person identifies as wanting involved in their treatment, and we can assess and respond to any safety needs in the person's natural environment and community. We can also assess ineffective interactional patterns and dynamics that may contribute to substance use patterns, and provide services that help address those dynamics and enhance family and social functioning. We know that a lot of people tend to experience a setback in their recovery in response to an interpersonal process, either having conflict with someone that they care about, or feeling really alone. And so this kind of social functioning and family functioning piece is really important for that continuing recovery. And then, of course, along with that, supporting effective interpersonal skills and healthy relationships. And here it becomes especially important to be aware of the dynamics of intimate partner violence and to really listen to the people in our services. Sometimes our services, sometimes substance use treatment has interpreted interpersonal effectiveness skills or interpersonal skills as assertiveness training. And yet, if somebody is experiencing abuse in their relationship and we're, telling them that they need to be assertive and training them on being assertive, that can really increase the danger and the violence that they experience within their intimate relationship. And so being really sensitive to the dynamics of intimate partner violence, building a space where intimate partner violence can be even talked about so the person can bring it up and tell us about it. And if a person ever says, assertiveness training isn't going to work for me, or this thing isn't going to work for me, we need to really hear that. We need to listen to that, because we don't have the whole story. We are never the expert on someone else's life. They are the expert on their own life. And so when somebody is, letting us know this thing isn't going to work for us, we need to trust that there's a reason, and we need to seek to understand and then individualize our services to them. And then community-based providers can include housing, healthcare, care coordinators, et cetera, trauma care, vocational providers, domestic violence providers, et cetera. And so how do we connect people with community-based resources? So first, assessing and anticipating post-treatment needs. So assessment isn't just something that happens at intake, it's ongoing. Cultivating resources and then supporting gradual transitions. In cultivating resources, we can leverage our social capital in helping to connect people with needed resources. So here, organizations often find it helpful to have linkage agreements, memorandum of understandings, different kind of service agreements with different community resources, and then having informed written consent to share information to facilitate transitions. And then within those gradual transitions, having transitions that are planned and coordinated so that we're all on the same page of how this transition is what's the timeline, or, who's gonna do what's our different roles. Whenever possible, having some joint transition meetings, and then bi-directional sharing of relevant information with informed consent. So this does not mean, someone signs a consent and we just send over their whole clinical file. Not everything in someone's clinical file is relevant. So being really specific that the things that are shared are with consent and on a need-to-know basis, and then sharing our follow-up and aftercare plans when appropriate. And then gradual transitions are especially important with medication-assisted treatment. That we know that when people experience gaps in their medication-assisted treatment, that can have really, really severe negative outcomes, including incarceration and death, and loss of housing, loss of employment, et cetera. And so really having intentional gradual transitions on medication-assisted treatment. So when I was working in an intensive outpatient and outpatient setting, and we provided MAT for people in our services, when people would be completing treatment with us, we would start the transition to their new MAT provider, who is often someone embedded in kind of office-based buprenorphine, like a primary care provider. We would start that transition process a full month before their completion of treatment. Because there could be missed appointments, it could take time to get an appointment, there could be, they had an appointment and they got sick, right? So all kinds of things can come up, and that we found that a lot of the times, sometimes it went smoothly and it only took a week or two. They had an appointment, they transitioned, everything was fine. But there were other times where, they had an appointment and a kid gets sick, or, they get called into work, something happens, and that we really did need that full month to make sure that people didn't have any gaps in their buprenorphine. So those well-coordinated transitions, these relationships and resources should be cultivated well in advance, and our staff need to have a thorough knowledge of the requirements for linking to our partnering providers. So having a sense of how do they take referrals, what's needed for them to accept that referral, and so we're not just handing a list to someone and saying good luck. If possible, we want to schedule the transfer MAT prior to treatment completion so that the person is still open and to active treatment with us in case there's any setbacks during that transition. And then with written informed consent, we're able to actively coordinate these transitions, including engaging in collaborative aftercare planning and follow-up support for the client, as well as potentially supporting the provider through consultation. So if this is a brand new relationship for this provider, there may be times where, transitions are just a hard time, and people can experience new symptoms or new needs or resurgence of symptoms or concerns that had been kind of addressed during treatment. And so with that written informed consent, us being able to support the new provider and being able to say, hey, yeah, that's something we worked on, and these are some things that helped, can really help smoothen that transition for the client so that the provider doesn't feel like, oh no, they need to go back to treatment, this isn't going to work, right? Because that's another way that gaps happen and people kind of fall through the cracks in our system. So what is aftercare? So aftercare follows the end of treatment, ideally when a person is ready to independently implement their continuing recovery plan. Now, we know that that's not always the reality, that a lot of times treatment ends prematurely because treatment is no longer being reimbursed, potentially, by the funding source, whether that's insurance or another source, or treatment ends because the person is ready to move on, feels ready to move on, but there may still be some concerns about kind of having a continuing recovery plan in place that feels practical and realistic. So aftercare can occur in a variety of settings. It doesn't just happen in outpatient settings. It happens kind of all along that continuum, and it includes an array of services. So, ideally, if the person still meets criteria for needing treatment, then they can continue to access treatment. But if that's not the case, despite our best efforts to address the barriers that they may encounter, or they've chosen to discontinue, we can still engage them in aftercare services. So aftercare can happen, for example, there can be periodic outpatient sessions that are individual or group. Aftercare services can include mutual aid or other recovery-oriented community support services. Aftercare can also happen in recovery-focused housing settings. Aftercare services can provide support also with some of the intrapersonal and interpersonal as well as environmental needs and goals in support of continuing recovery. So I'd love to invite everyone to put into the chat box, what kinds of aftercare services does your program offer? So I see follow-up survey. That's great that you're providing some of that follow-up and checking with people around where they are and how's it going. Vocational services, it's so important. There's so much, substance use disorders can have a really negative impact on our employment and how do we explain gaps in employment and things like that. And so the vocational services are really, really important. Community-based resources, post-treatment appointments with mental health and rural health programs, both inpatient and outpatient. Case management and community follow-up programs in the community, absolutely. Outpatient therapy, a mentoring program, that's great. I think that we don't do enough of some of that mentoring program. Alumni groups, aftercare groups. Great, a lot of great aftercare services happening out there. Thanks, everyone. So, aftercare services can include services that support the community of treatment alumni, recovery support services, recovery coaching and peer-based support, and recovery management checkups. Here, it's really any service that is helping people with tools, resources, and safety strategies while supporting connection within community. We don't want to send, so I often think of, we don't want to send people off on a hike without the proper tools, resources, and hiking buddies, right? We don't want to just send people off into the wilderness to fend for themselves. So, and even with comprehensive discharge planning, many of the realities of continuing recovery post-treatment don't become apparent until the person is in the situation. And this is just human nature, right? That we can't anticipate everything and we can't anticipate what all the different challenges or our needs may be in a given situation. So this makes aftercare, the aftercare plan and access to aftercare resources that much more important for supporting long-term recovery. So in the alumni group, or alumni community, we can have established alumni groups, recovery celebration, and then alumni family events. So building alumni community of peer support, recovery-oriented celebration, and family bonding not only supports ongoing recovery, but can also help ease anxiety and loss that naturally comes up as people move towards treatment completion. So it sense that, what I've gained here and what's helped me gain that, that my sense of community here isn't just going to disappear once I complete treatment, that there's still ways that I can be in touch. And that when we are planning events and services, we want to take into account what is responsive to alumni needs, preferences, as well as culturally relevant and inclusive and responsive. And what is included in recovery support services? So here, thinking about, so this is just a limited list. There's a lot of other kinds of recovery support services that can be provided. And so in thinking about these recovery support services, what is your programming already providing directly as well as through collaboration with community resources or referrals during aftercare? And feel free to put in the chat some different things that your program already is providing. And something that I want to mention here too is that a lot of these services can also be available through local recovery community organizations. And for people who have experiences of intimate partner violence, whether it's kind of active and current or something that is maybe more in the past, but they may experience some ongoing targeting by like an ex-partner. A lot of these services are also available through your local DV organization, your local community DV organization. And a really great resource to find out more about what might be available in your community, as well as just how to better support survivors of domestic violence, is the Florida Coalition Against Domestic Violence. And I have them listed as a resource on one of the final slides. Really strong coalition and really want to work across fields and collaborate to support any survivors. So recovery support services seek to increase recovery capital and help individuals and their families to build a life of recovery. So these services are often offered by people with lived experience or the family members of people with lived experience. But they can also be provided by volunteers or paid staff or linked to in the community. It's important to have effective communication and coordination when there's multiple people involved in providing recovery support services. So that team approach is really helpful. We can always accomplish much more as a team than we can just, working individually or siloed. And while these services are an integral part of aftercare, they need to be interwoven throughout pre-treatment, outreach, and engagement services, as well as during treatment. So some people might ask, where's the boundary between increasing recovery capital and enabling people who are not yet pursuing recovery? And that's a pretty common question. And to answer that question, it's vital that we shift our perspective to understand that increasing recovery capital doesn't enable use. What it does is enable staying alive and engaging in recovery. And within these services, the importance of recovery coaching and peer-based recovery support. Now, this can be offered in-house as well as connected through local recovery community organizations. And knowing that healing is relational, especially in the context of trauma, which we know that, that trauma is a huge risk factor for substance use, and substance use is a huge risk factor for trauma. That when the hurt happened in relationship, the healing also happens in relationship. And so recovery support services and peer-based recovery support have a wide evidence base and play an important role in person-centered, trauma-informed, and holistic approaches. Now, while the hurt happened in relationship and the healing happened in relationship, we can't always predict with whom someone will be able to connect. So for people who may naturally experience a lack of trust because of a history of past betrayals associated with either individual or collective trauma, there may be times when connecting with a peer will be much easier and powerful in their recovery. And this is where the importance of that interdisciplinary team becomes really apparent. The recovery coach is well positioned to be the consistent source of support as someone moves through different phases of treatment and non-treatment, making transitions smoother and more successful. They can engage individuals from that outreach and kind of pre-treatment point. They can stay with them throughout the different levels of care, and then finally during that aftercare phase. So for treatment providers who want to employ recovery coaches as part of their comprehensive interdisciplinary team, it's really important that providers increase their ability to nurture and effectively supervise recovery coaches as recovery coaches. This is a very special role, and without the proper training and effective supervision of recovery coaches, sometimes we can default to trying to make recovery coaches into simply case managers or junior clinicians or clinician assistants. I've spoken with many programs where it's like the recovery coach, all they're doing is kind of like transporting people, and they're really missing out on the richness of this role, of everything that this person has to offer, and really deepening the continuing recovery of people in the program. So it's not enough. It's really important to employ recovery coaches as part of our programs, but it's not enough just to employ recovery coaches. We also have to know how to effectively nurture and supervise these interdisciplinary teams. And then recovery management checkups. So here, recovery management checkups was born out of the idea of what other chronic health conditions would simply treat someone and then never follow up, right? We don't see that happen really in any other kind of treatment of chronic conditions. And so in some of the research, it was found that people who access recovery management checkups versus those that did not were significantly more likely to return to treatment sooner and receive more treatment when they needed it. And so this is something really important to notice, because people, right, many people will experience cycles in their substance use disorder. But the last thing we want is people waiting until things have gotten really, 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 really bad and then accessing some kind of care. We want to help support people as early in that process as possible. So recovery management checkups not only support continuing recovery, but they also help kind of wrap our arms around people and re-engage people in needed services when they start to experience some of those early signs of a potential return to a substance use disorder. So recovery management checkups have some core components. One is quarterly check-ins, and then motivational enhancement techniques to provide personalized feedback, help resolve any ambivalence around substance use, and then engaging people through treatment linkage, and then engaging and retaining them in those services. And they can be done over the phone if needed. And recovery management checkups have been found to be significantly effective, even for people who are assessed to have more severe courses of substance use disorders. And in order to practice motivational enhancement, get trained in motivational interviewing. I like to say my students at the University of Chicago often laugh because I'm very known for saying motivational interviewing all the time for all the things. So many may not reach out until they're in crisis. And as treatment professionals and recovery specialists, we can reach out, follow up, and truly make a difference with something that can be as simple as a phone call. So it supports long-term recovery by not relying on the assumption that people will or can notice the early symptoms of a substance use disorder and reach out when treatment is needed. Now, that said, our approach is still trauma-informed in that it's not shaming, it's not blaming, right? It's about engagement, being inclusive, welcoming, invitational, having compassion, empathy, and partnership. And this is where using those motivational enhancement skills from motivational interviewing become really important. So challenges in providing aftercare services. Funding is always a challenge, no matter what we're trying to do, right? Funding is always a challenge. Geographic service areas, high caseloads, and then, of course, disengagement. And we'll talk about that. So, most funding sources do not yet pay for aftercare services. That's an unfortunate reality, despite aftercare services being very cost-effective, having potential kind of life-saving effects, and having a high return on investment. So there's a lot of studies showing that kind of ongoing aftercare services and care coordination found improved outcomes, while costs and demands for acute care, which is very costly, can be reduced. So it's one of those things that while insurance or funding sources may not reimburse for it always, it's almost like we can't afford not to do it, because we know that it not only represents cost savings, but it can help save lives. So if and where funding and reimbursement does not include recovery support aftercare services, we can advocate for adequate coverage while also recognizing that these services not only contribute to improved recovery outcomes for clients, but also maximize the effectiveness of our services. So, geographic service areas. Some things that we can do. So particularly if we offer residential treatment services, many times the people who have completed treatment with us return to their communities, which may or may not be close to our treatment center. And even in outpatient settings, people often move to different locations in pursuit of new opportunities or to rejoin family. This can make it more difficult for people to return to our setting to access aftercare support, as well as make it harder for us to be able to provide aftercare services in people's homes or communities. Technology can be helpful in managing high caseloads. Technology can be helpful here. So helping to use phone and telehealth, and having, connecting with local resources in their community, and then collaboratively creating a really clear follow-up plan. So that these are some of the things that help us overcome some of the barriers that are presented by just, people not being close to where our offices are located. High caseloads. For many of us, high caseloads are a reality. And so some things that can help here, supporting a culture of mutual aid and alumni community, collaborating with recovery community organizations, and offering group-based aftercare services. And not just because groups are helpful with managing high caseloads, but also because they help to develop that peer support and help people connect with an alumni community. So in a lot of ways, it's a win-win. Technology can also be useful in managing high caseloads if people have access to smart devices and websites and feel comfortable using them. There's a lot of different kind of applications and websites that can help with continuing recovery management as well as building recovery community. And then in thinking about in some of supporting the unique and specialized needs of women in aftercare services. And I'm going to focus on women for a moment because women have unique experiences and needs that often go unaddressed in our treatment system, which in turn results in higher rates of dropout and attrition and poorer recovery outcomes. And so we, talk about disengagement being a barrier to providing aftercare services, and women are kind of disproportionately at risk for disengagement because of their unique needs not being addressed in many of our treatment systems. So some of the things that helping to address barriers, including resource advocacy, flexible scheduling, and in-home services, women-only and gender-responsive services. Women in particular tend to come to treatment with high rates of experiencing sexual violence, inter-partner violence, childhood physical and sexual abuse, just a lot of trauma. And multiple studies have found that women-only gender-responsive services increase treatment retention and post-treatment engagement in aftercare services, and that this is especially true for those who have experienced trauma, to be able to access support around how experiences of trauma and abuse impact their continuing recovery. For many women, they're not going to feel comfortable or like they can get their needs met in a co-ed group when a lot of their treatment needs are going to involve addressing some of that, gender-based violence and childhood physical and sexual violence and abuse. One study conducted by Sterling et al. In 1998, they had an IOP, and they found that women who were treated in women-only groups and had a feminine-identified counselor at discharge were found to stay in treatment longer, as well as engage in outpatient and community-based care post-treatment. So really kind of highlighting the need for women to have access to women-only groups and feminine-identified counselors. Now, that said, we would never tell a woman, hey, you need to meet with this, female counselor because that's better for you, right? That's not trauma-informed, that's not helpful. But having options available for women to choose from and to make their own choices. Case management support, especially for those who experience concerns related to housing or parenting. Peer-based programming. Interestingly, there's been research that has found that women who experience emotional dysregulation and or have more complex problems, because we know that women tend to experience higher rates of co-occurring problems as well as higher rates of resource scarcity and poverty, that women who experience emotional dysregulation and more complex problems were found to more readily access peer-based programming, that they were engaged and retained much more in peer-based programming than programming provided by kind of licensed credentialed treatment professionals. And then, of course, whenever possible, coordinating mom services with children's services. That being a mom is a full-time job. As a mom, I say being a mom is a full-time job, and then on top of that, to be engaging in our recovery and all the different kind of co-occurring needs that any one of us may be experiencing, that anything that we can do to coordinate kind of that family-based piece will really help with addressing improving retention. So what can we do for the next steps? Here are some ideas just to get you started and things that you could try, things that you could look at, some places just to take some of the things that we talked about today and start applying them to practice. So establishing a discharge planning protocol and training all staff involved in discharge planning. Beginning discharge and aftercare planning during the intake process. Use clinical staffing and supervision to review upcoming discharges and discharge plans. And I think it's really great practice to include people, invite people in attending. And when clients would take us up on attending that clinical staffing, it's always nice to have some food and kind of break bread together. That can be really engaging. Nurturing peer support and alumni community, expanding our aftercare offerings and follow-up, implementing recovery management checkups. And as we talked, it can be as simple as, a phone call every 3 months. It doesn't have to take a whole lot to get started there, and yet it can have a really big impact. Connecting with local recovery community organizations, as well as just other community organizations in general, and creating linkage agreements and engaging in cross-training. A lot of times when we can offer cross-training, for example, to our local DV organization and, share with them what we know about substance use, and then also hear from them all of their expertise around domestic violence. That not only benefits our staff and our clients, but it also really helps forge those relationships. And we know that everything happens in relationship. We're social creatures. Here's some different resources that I've mentioned throughout, as well as some additional ones. Faces and Voices of Recovery, Advances Treatment Locator, the Florida Coalition Against Domestic Violence, the Florida Association of Recovery Residences, and the Florida Division of Vocational Rehabilitation. The references, some more references, and then my contact information. I'd love to say thank you before I open it up to questions. All right, so looking through some of the questions that have come in. So there's one question around whether housing assistance and services could include shelters. Shelters are absolutely an important resource, especially important for us to have working relationships with different shelters, and with different shelters that maybe specialize in different kinds of concerns. DD shelters, absolutely, as well as just emergency and just homelessness shelters. I found a lot of times that when I was working with somebody who experienced housing instability and had become homeless or came to our services and was experiencing homelessness, that it was really important for our team to have a close relationship and communication with the shelter, because the people that we served were at really high risk of having conflict with different staff that worked in shelters, as well as getting kind of turned out from the shelter. And especially because so many of the people that we're supporting have experienced trauma, that a shelter environment can be really challenging for someone who's experienced trauma. There can be a lot of rules. You don't really have a whole lot of private space. So it's not an easy situation for any of us to live in or sleep in, but especially for someone who may be experiencing trauma and concerns related to substance use. And so I found that many times through having those active relationships with shelters, that I could really contribute to preventing our clients from getting discharged from that shelter, because I could provide support around helping the person to understand what they can do, as well as just advocating for our client. There are some questions around list of references, and so these slides will actually be posted online, so you'll be able to access those references. And then there's also a question around the websites as resources. So there's just a handful of those, so I'll go back to that slide so people can screenshot it or write them down real quickly. Let's see. What are the components of our relapse prevention program? So it depends on what we're kind of talking about. If we're talking about relapse prevention therapy or a relapse prevention program, which can be certainly related and connected, but might refer to different things in some different contexts. So relapse prevention therapy is going to include It's a cognitive behavioral therapy approach to continuing recovery. And so it's going to include a lot of those coping skills, as well as building a life of recovery. So, for example, building leisure skills, building interpersonal skills, building vocational skills. And then it's also going to focus a lot on being able to recognize the kind of the seemingly irrelevant little mini decisions that set us up for a high-risk situation in terms of potential for relapse or kind of a setback in our recovery. And so a lot of what gets used there in that kind of cognitive mapping is behavior chaining, and then using that behavior chain to make an even stronger recovery plan. And so a lot of the pieces that are involved in that actually I included in the discussion today of continuing recovery planning. It's a very evidence-based approach, and I highly recommend integrating it to whatever existing approaches are being used. And then in a relapse prevention kind of program in general, if we're not talking about the specific therapy, then I would think that there would just be attention to awareness around kind of cues for use and craving experiences, and what we often talk about is like people, places, things. Attention to that kind of that discharge planning like we've talked about today, as well as a lot of focus on coping around how do I cope with the kind of high-risk situation, as well as the internal kind of feelings or craving experiences that can come up that might be a cue for a setback. And so those are some of the major components of a relapse prevention program, where we're really focused on maintaining the gains in recovery, and it'll overlap with a lot of what we talked about today. Let's see. So here's one question. What would you recommend when we are lacking facilities for men with criminal backgrounds? This is one of the reasons why people relapse or commit another crime. When there's limited facilities in the community, they turn to crime because they know jail will help. So there's absolutely a huge need for evidence-based and effective community reentry services, especially given the vast amount of people who are incarcerated because of substance use or have some kind of legal contact because of the criminalization of substance use, and that it becomes a really vicious cycle for people that without the proper support, that it's so hard to escape that cycle. And that we know that the problems of substance use disorders, we're not going to arrest our way out of that problem, and that we're talking about a health condition that needs support and resources and engagement. So what can we do? Connecting with any available reentry services that do exist and seeing how we can collaborate to add a recovery component to them. Collaborating. I know there are many recovery community organizations that have added kind of specialized support around reentry needs, because so many people who use substances end up with some kind of criminal legal system contact. And then, of course, advocating for funding as well. I know that there are some really promising models coming out of different states that have been funded by the state, and that showing that peer-based recovery coaching for people who are leaving legal institutions and re-entering the community, that it's really effective for them, both in reducing recidivism as well as in their substance use outcomes. And that vocational support is often very much needed as well. And CBT can be a really great approach for this population, very evidence-based.
Alrighty, Gabriela and participants, if there are no more questions, we'll go ahead and conclude today's event. Thank you so much, Gabriela, too. It's always a treat when you're on these webinars.
Thank you. Thank you so much for having me, and I hope to see and meet many of you when I'm there in February.
All right, looking forward to it. I'll take control back. When I conclude today's webinar, your browser will take you to an evaluation on SADA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost for CEs to be reported to CE broker for FLA licensing healthcare practitioners. You must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or log in, you will be directed onward to an evaluation. You may consider using the same email when you register for webinars through our WebEx link and when you set up your profile in SADA system. This helps connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today in about 30 minutes. The sender will be messenger@WebEx. Evaluations will close Monday at midnight on Saturday, January 18th. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families Offices of Substance Abuse and Mental Health for funding today's event. Have a great rest of your day, and please hold on for the evaluation.